Good afternoon. We're going to get started shortly. We're going to give a minute or so to let everyone join us for this Friday's National Minority Equality Forum webinar. We're so excited to have you join us with Breast Cancer Action Month. All right. I see the attendees coming in. Good afternoon, everyone. If you're coming in, feel free to join us by saying hello in the chat, letting us know if you've been impacted by breast cancer. You can say a yes, a no, a Y, a N. We'd love to hear from you. Hello, Brandon. Hello, everyone. Excellent. We're going to give it about another minute to just let everyone join us. And then we are excited to get started with this conversation. I know you're going to enjoy it. I'm having a chance to sit down with one of my favorite advocates in the breast cancer space. And I think you're going to learn so much from her story as well as her journey as a physician and a patient. All right. So again, if you're just joining us, feel free in the chat to say hello. Let us know if you've been impacted by breast cancer or cancer. We know that it is Cancer, we like to say Action Month. We know that it started off as awareness, but we are moving from awareness to action. And I'm Shyrea Thompson. I'm the founder and principal of the IRIS Collaborative. And I'm also a National Minority Equality Forum advisory board member and a 40 under 40. And I'm honored to be here with a friend who has been a leader in the fight, not just for patients, but also for clinicians and health equity, Dr. Lori Wilson. She has recently been promoted, and she is now a full professor of surgery and chief surgical oncology program director of general surgery residency at Howard University College of Medicine and Hospital. So I'm going to pause and say a very warm welcome to my dear friend, Dr. Lori Wilson, who has always been a rock star, but recently just leveled up again. Hi, Dr. Lori.
Hi, how are you doing? Thank you for that.
I am so well. I'm excited to have you here this Breast Cancer Action Month. And when NMQF reached out, we thought this would be a great opportunity for us to really talk again about what does it mean to actually be on the journey from physician to patient. And Lori is passionate, as am I, about advancing equity. So we thought, why not call it a Breast Cancer Action Month conversation? From physician, to patient, advancing equity through advocacy. So we're gonna go ahead and get started, and we're gonna do it kind of like an Ask Me Anything. I've got a couple of questions that I'm gonna get started with Dr. Lori, and we have resources that we're happy to share. We have tools and insights as well for you. So if there's a question that you have, please feel free to put it in the Q&A. If you'd like to engage in the chat, also do that. We'd love to see who's joining us. What's your perspective? Are you a patient? Are you a policymaker? Are you a physician, a clinician, a navigator, a community leader? We want to know that. And then also, if you have questions for Dr. Lori, please feel free to put them in, and we're going to get started and weave those in as we go. So Dr. Lori, I figured we'd start with the first step, right? You first were a physician long before you might have been a patient or a patient advocate. And I had the chance to start working with Dr. Lori Wilson here in the DC area. Her story is one that I think inspires so many. But if you're new and you've never heard about Dr. Lori Wilson or how she got started, I thought this is a great way to open up. So Lori, can you tell us a little bit more about why medicine and why did you become a physician?
Thank you. I want to begin by, of course, thanking you for the opportunity to come on and share in this moment. I'm currently at Howard University Hospital and College of Medicine, as you all know, in Washington, D.C. I bring greetings, of course, always from my chief, who is Dr. Wayne Frederick, and my partner as a surgical oncologist. You know, I think back and when I originally decided I wanted to be a surgeon, and that actually is many years ago, but I was 7 years old when I first decided that I wanted to be a surgeon. And it was because of the show MASH, and I think I'm probably telling my age But there was a show called MASH, and it had a character on it called Hawkeye. And he was a surgeon who could do anything and everything. He could operate on patients and do just about any surgery, and they would always survive and always had great outcomes. And in my mind, that was one of the greatest things. You could help people. You could learn this wonderful thing that you could bring to your community. And so I'm sure when I told my parents at 7 I wanted to be a surgeon, they were like, we don't know how we're going to do this, but we're going to get it done together. And I say that because, like many of my friends and colleagues, I'm first generation. I'm first generation going to college. I'm first generation going to medical school. I'm first generation having this amazing opportunity to really move up through the academic ranks of medicine. And so I began with my very first opportunity to understand the importance of academic medicine by having a summer program that was a pipeline program that allowed me to learn about research. And this was at Eastern Virginia Medical School because I grew up in Portsmouth, Virginia. And one of the wonderful things about that was it gave me an opportunity to understand what it was that they were doing. Why did they do it? And one of the major things that I got out of that summer as a 16-year-old was that the highest ranking that you could receive as an academician is to be professor of whatever area that you selected. And so in my mind, in my 16-year-old mind, it was what I was going to do. And the fact that I was actually promoted to full professor just this year is the culmination of all of these wonderful opportunities, all of these people who poured into me, all of these really great programs that and opportunities to really grow and understand what medicine really meant. And then ultimately to feel that I could come back to my community and practice. And so that was my goal. My goal was not only to be a professor, but I was going to come back and serve my community.
I love that. And I know that you have been standing on the shoulders of giants, and we're going to hear a little bit more about that coming up. And I know that when you had an opportunity to share your story, once again, you didn't shy at that. You became a patient and also had the opportunity to represent your story in a really unique platform with the Emperor of All Maladies. I don't know if anyone's in the chat and you got to see that series years ago. But what always struck me, and I got a chance to meet Lori actually that year. She came to a summit we were having in DC, and she was quiet in the back, but watching everything. And I got a chance to ask her, why did you say yes to this? And what really struck me was that she wasn't the Black face of breast cancer. She wasn't the white face of breast cancer. She was the face of breast cancer. And she did it in such a way that, for us in this space, it was so transparent. You let, the cameras into your home and you shared your story. You showed what it was like to be a mom, to be a wife, to make these next steps, but then also what it meant to be also a physician in tackling these choices with that first step. So can you tell us a little bit more about when your journey shifted and what did that look like when you shifted from being a physician to now you're also a patient?
For me, it was 2013. And for those of you all who don't know me, I am a surgical oncologist. And so I spent every day taking care of patients, partnering with patients and helping them to understand what the word cancer really meant. What does it mean in the understanding for them? What does it mean? What did it mean for their journey, what treatment plans did they have, and ultimately what did they have to look forward to? So when I had my own diagnosis, it was, of course, I knew about cancer. I was devastated because I, as many women in surgery, had delayed a bit of my life to get to and through my medical school training, my residency, my fellowship. And so I was beginning to lead the life that I had always dreamed of. I was married with my son at that time was 1.5 years old. And it was the moment that I had to decide, how was I going to get through this? And how was I going to share this? And the Ken Burns documentary gave me the opportunity to really share what isn't really seen oftentimes. Of course, the office visits, of course, those moments where the surgery happens, and those things are definitely moments that I think we're all very familiar with. But it was those other moments, those quiet moments of humanity that I talk about, those moments where you are sharing in the experience of losing your hair. Having that moment where everyone, my husband, my brother-in-law, and some of our good friends all shaved our heads in solidarity, so that it wouldn't be something that was not out of our control, but in our control. It just really gave this opportunity for us to understand all of the goals that we have in our lives. You know, for me, it was to see my son grow up, to go to grad school, you know, and to make sure that he was cared for well, and that I could do that, and that I was going to be able to do that. And so that shifted my world dramatically, because at the beginning, you don't know, what's going to happen to you, what you're going to do. And luckily, I had a wonderful team. I had a great opportunity to share and just to be open and transparent about every moment that the experience had. And then through many of those experiences, I got an opportunity to share with some of the greatest mentors I've had in my life. One of the mentors is Dr. Armando Giuliano. And for those of you all who are surgical oncologists, you all know that he was the one who developed the sentinel node, transformed the way that we look at evaluating lymph nodes in women, giving less poor outcomes for things such as lymphedema, and gave us an opportunity to stage women. So he was my mentor, and ultimately ended up being my surgeon. And so it was some of the most difficult moments of my life, but also some of the most special moments, because it gave me an opportunity to share with women who look like me the experience of what breast cancer and diagnosis and treatment looked like. And so it was a phenomenal opportunity for me. And I think an opportunity that resonated with so many others, not just about the experience of cancer, but being a mom and having cancer, being a mom with a toddler having cancer, being able to, for those, they're more than you think, clinicians out there who've been diagnosed with a cancer and having to, and it really resonating with them, how it impacted the way that they interacted with their patient population, and how oftentimes this new level of complexity of understanding, as well as this new kindness and this new sense of really trying to connect with your patients and doing all that you can so that they would have the best out of you. And I think it just, for many of us, transformed the ways that we looked at those things.
Definitely. And I know that we had a chance through your journey to continue to work together. And Dr. Lori Wilson in the DC area, started to share her story. We, went to the Hill, and over time, I remember we actually were headed to the Biden Cancer Summit, and actually NMQF's Dr. Gary Puckrin, he presented the indices, and there was a great day of camaraderie in the cancer space here in DC and across the country. And I remember that was coming up on your milestone. You were reaching the, standard of that 5-year mark, right, of survivorship. And for those of you that may not know cancer, oftentimes, particularly in breast cancer, that's a milestone where many people feel, okay, I'm there and I'm in the clear. But we know that with breast cancer, particularly with Black women, and understanding more about the genetics and the way that breast cancer develops is really key. And so as friends and as sisters in the fight, we celebrated that moment, and then winter came. And in the winter, January of 2020, you called with your update, and it was not quite what we had expected, right? And it was that your cancer not only was back, but that it had spread. And I think that at that time, one, for me, I couldn't think of anyone that, Lori is one of those doctors that is going to do the most she absolutely can for her patients. But to think of now she's moving in the next phase of her career, celebrating that milestone, being a mother, getting her son into, school. Now you've got to think, how are you going to move on with the next phase of your life? So can you share with us, Lori, what was your next step from there? And where did you go with that change in your journey?
It's very interesting because I think that when I first started having back pain, I had just come off of a trip, as you know, and I was thinking, I have this back pain, but it's probably because I was carrying, the big luggage. And so I went to get checked out because anything that's new and different and persistent, we teach our patients, that's something you need to bring to your clinician, your provider. And so I did, and not expecting to hear, honestly, I wasn't expecting to hear that I was metastatic. And so knowing that I was metastatic, I had to then understand, what did this mean for me? As you all know, metastatic disease, the metastatic space has really grown. There's been lots of understanding about the metastatic space and what it really means for patients. One of the things that we do know is that a third of patients, or almost a third of patients with breast cancer initially diagnosed non-metastatic, will become metastatic during their time frame. And so I became one of those patients. And then I had to figure out, could I still do what I do? Could I still work? Could I still take care of my son? Could I still do the things that I felt put on this earth to do? And so for me, it became about trying to identify, what is it that is going to be my next step? How am I going to use this to make sure that I am as healthy as well? And I am communicating this with my team. And one of the things we've talked about is how important it is to have this multidisciplinary team, this team of people who listen to you, who understand who you are and what your goals are. For me at that time, I had, my son was 7 years old. And so I was looking, of course, to be more aggressive. I was looking to make sure that I had all the opportunities to live as long as I could. And so those were the ways that I came to the understanding of what my options were for clinical trials, what my options were for standard treatment. What did it mean for me And what was I going to do to make sure that the people who were taking care of me, I was also advocating for myself. I think that we think of that as being an easy thing because as clinicians, I think many of us think, oh, I'm so easy to talk to, so easy to share with. But I found I had the same concerns initially as I think most of my patients do. Will they hear me in the way that I need to be heard? Do they understand I have a 7-year-old? I need to be here as many years as possible. Metastatic for me does not just mean that I can just wilt away. I need to fight. I need to do these things. And so luckily, I have had some experiences that have aligned themselves with that. Unfortunately, I've also had experiences that have made me feel as though I wasn't important in the discussion. That what I had to say and what was important for me as a woman, as a clinician, and this is as I was traveling around getting opinions about what was necessary for the next steps for me. And so what I found is that there were some wonderful clinical trials and wonderful clinicians out there. But I also found people who really did not hear me. And I had the same experience as some of my patients. As you all probably know, Howard University Hospital is where I work, and it is an HBCU, historically Black college and university. 95% of my patient population is Black. And so we don't think of patients as being monolithic. I mean, we have to understand that my patients they come from Africa, they come from the Caribbean, they come from the US. So I have African American, Afro-Caribbean, I have African patients in my population. Each and every one of them bring a different understanding, a different concern, and a different background. And so from a cultural humility standpoint, it is important for us to understand where they're coming from and what they're bringing along with them. And so those were I think the major points that were important for me. And so I'm hoping that with this group that we have, that we will begin to think about what does that communication look like? What does listening look like? And what does understanding what your patient is really trying to accomplish? And can you do that for them?
Well, I think you're one of the most equipped people for that.
So let's say I not do that for them, but do that with them, because it ultimately is the partnership that we really talk about.
Definitely. And I know that's one of your priorities as well. And so when you think about that partnership or creating more opportunities for that partnership, you hit on some things that I think people might be surprised to hear, that an oncologist, a physician in 2020 and 2021 is having challenges themselves, right? Coming from Howard University and going to renowned care centers and facing a lot of the same barriers that we see as patients, that we work through as advocates, as patient navigators. And I think that that's one of those reckonings, right, that we have to have in this space. You know, I think as a country, as a field, we've all been talking about, right, those isms, the schisms that create these dynamics. But what I love about what Lori has done is that she took her experience and you turned it into purpose. And you said, okay, that might have happened to me, but here's what's going to be my next step. Here's how I'm going to proceed as a patient, but then how am I going to change things for my patients and for patients everywhere and change that landscape? So Lori, can you tell us a little bit about how you have turned that into purpose and how you're moving forward with those challenges that you've had even recently to make sure that there can be more access for patients?
And so we really talk about access, and we talk about understanding, and we talk about collaboration with our patients. One of the things that I'm always have loved about being part of Howard University is the legacy. The legacy that comes with that for me in surgical oncology, it comes with the legacy of Dr. LaSalle-Lafall. For those of you all, Dr. LaSalle-Lafall was a wonderful clinician who transformed the world of surgical oncology. And he stayed at Howard University and invested in students, residents, faculty. Just an amazing man to begin with. He was the second African-American to be trained at Memorial Sloan Kettering, the first being Jack White, who was a radiation oncologist, and of course, Dr. LaFall being a surgical oncologist, and one of the many people that has had amazing impact in the direction of my life. Knowing that Dr. White was trained first, Dr. LaFall coming next back in the 50s, they were two of the group of multidisciplinary clinicians before they called it multidisciplinary approach to care, who came back and brought that to the Black community in Washington, D.C. They met as a team, looking at pathology, looking at the radiation radiation plans. They looked at the surgical plan for a patient. They looked at the medical oncology plan and put that together as a way of developing and understanding how to care for a patient. And so I was blessed enough to have the opportunity to give a commencement speech at Memorial Sloan Kettering after having done the Cancer, the Emperor of All Maladies. What that actually really brought back to me is in the research of figuring out how and what it meant for those two organizations to come together. It brought to me the understanding of what Dr. LaFall did to really understand what the community needed and how he was going to make change. In that, I am program director of the general surgery residency at Howard University. I have 33 amazing young, diverse residents who I've had the wonderful opportunity to train. Part of that is knowing that one of the major disparities for our community is cancer. I thought, well, how can we begin to change the dynamic of cancer? How can we begin to change the ways that cancer patients are treated? How can we make sure that this new generation of surgeons has the best possible training in cancer surgery that they can? And so as program director, I was able to collaborate with Memorial Sloan Kettering, and we have the ability now to send residents to them for them to get the best possible surgical training, which they will ultimately not only learn about how to operate on very complex surgical patients and bring it back to our community, but they'll also learn how to integrate clinical trials into the management of their patients and from a surgical standpoint. So I thought that there was no better way for me to ultimately leave my legacy is then to develop this collaboration. And it really is about developing the collaboration that is unique to your institution. It doesn't have to be a collaboration with, a cookie cutter sort of perspective, because ours definitely wasn't. It was an opportunity for our two organizations to come together to provide mentorship, to provide clinical understanding, to provide the best in what we know of for clinical trials, and then teach our residents, who will ultimately each probably see thousands of patients themselves. Not all of them will go into cancer, but some will. But they'll bring it back to a community that hopefully that they will then interpret and will give an understanding of what these things mean to them, to our community, and hopefully will have a long-term impact on the disparity of cancer. So that's just one of the small things that came out of the ability for us to work together. But to think about, how can I use my space? How can I use my opportunity? How can I use what has happened to me to potentially change the way that we do things and ultimately change the outcomes for thousands of patients? So I'm really excited that this is how we were able to do it. But I know that hopefully using that as a as a springboard, that each organization will think about, how can I uniquely use what I have in my environment to make these things happen for my community and the community that we serve.
That's excellent. That actually takes me to our next question, which was actually about tips. And so I know you just gave one for those leaders at institutions. I love that, about how you're crafting, right, that opportunity that meets your institution's need. Oftentimes you talk about advocacy being one of your passions and your platform, right, for advocacy. And I think you do it in a way that's unique. It's not always, you've got to go to Capitol Hill and tell someone to vote this way. Advocacy for you can be about action and what it looks like, whether you're in policymaking or even in community. And so do you have any tips for those who are listening that might be advocates themselves or working in community that you would just share about getting some of this work to advance equity done in their own space?
And, I think that one of the important things is that developing out of the resources that you have in your community. We have a small faculty in comparison to many institutions, but what we know is that our faculty is really diverse. They are very committed. I love the people that I work with, and that they are willing to put in the work to figure out what each organization or what each patient group may need. And realizing that it doesn't have to be this huge advocacy effort, that it can be a small effort that ultimately reaches a group that you have targeted because of the expertise that you have. So meeting patients where they are, making sure that it's patient-centered, making sure that the advocacy that you provided is dedicated and focused on the population that you serve. So I think one of the things that's hugely important is knowing who you're serving. I understand the population I serve because of the many events that we've had, of course, many of the sit down opportunities that I've had with each and every one of my patients, which I love. I have the opportunity not only to talk about what's next for patients and their treatment and advocacy, and making sure that they understand who they are and what they want and how can we help. But I honestly have patients who, for instance, tell me when I'm supposed to plant my basil, or when I'm supposed to, what books I'm supposed to read. So even connecting on this very pure sense of just being part of the community is a big part of what we should be doing. And then also making sure that the advocacy is focused on who our patients are. As I said, I understand my patient population. The vast majority of my patients are service workers, which means that if they don't work, they won't get paid. And so sometimes the decision making has to be a bit more novel about when we get things accomplished or how we get things accomplished because of that. I also understand that the population of my patients, the income for that population of patients may be a family of 4, and the income is $24,000 to $25,000 per year, which means that there are different decisions that are oftentimes being made than some of my other patient populations that are in Washington, D.C. I was looking at the median income for Washington, D.C., and I saw that the median income was over $100,000 per year, but that's not who I'm serving. My patient population is disproportionately led by a single person. Typically, that single person is a woman. And so how does the social and determinants actually impact my patient population and how they may go about making decisions for their family? Oftentimes they'll make decisions for their family members before they make decisions about themselves. And so understanding those things has been changed the way that we have offered care. We've had the ability to do a multidisciplinary clinic that allows patients to come in and see all of their providers at the same time. And so realizing that if they only need to take 1 day off, that's much better than having to take 5 days off to get all of the things that they need to do. And so it is oftentimes not only about understanding the policies that are in the bigger picture that are available for your patients, but also in what it is that they have for the smaller day-to-day. That's going to make their life much easier and much more likely to make decisions that are going to be healthy for them.
Excellent. So I'm going to give my warning. We are about to have an opening for questions. I know we already have one in the Q&A that we're going to get to. If anyone would like to submit any additional questions, feel free to get them in. I'm going to ask Lori my last question before we open up for Q&A. So you mentioned change, Lori, and I think that if you think about your journey, you've been in this space for quite a long time, and we've seen so many changes. So for you, what do you think has changed in the breast cancer space, whether it be from equity, male breast cancer getting more attention, patient-centered care, increasing access to clinical trials? What do you think are some of the things that you've seen change in advance?
So I think patients having a voice and being able to come together in organizations that are heard in spaces such as SABCS, and that they understand what their goals are and then can really communicate to those who are making policy and decisions and who may be pharmaceutically based what their needs are. Patient-centered care. I think that, we have moved away from cookie cutter care. We know that there's targeted therapies. We know that there are a focused understanding for risk models, specifically for instance, for screening, using genetic makeup and history of risk factors that can help us sort of understand what it is that we need to accomplish. I really believe that it's been an opportunity to really have work that advances the detection and treatment and understanding, and that patients are expecting that. And so that is definitely something that's new. I'm having more patients who are really spending time investing in understanding what they need before they come to us to do they've done their research in these really wonderful opportunities and spaces that give information. So they're preparing themselves, and I love that. So those are a few of the things that I've seen over time. And then I expect that the advocacy and understanding what the financial needs, especially in the metastatic space, are needed, and what the policy should be, so that those that may be changing where they are in their financial space or in their overall space knows where to go to for resources.
That was comprehensive, but I think that that's actually a great segue, because when you think about resources, Kristen Hobbs had actually shared a question, and she's been another friend of the fight. Earlier, we were actually talking about one of Lori's favorite resources is the Know Your Girls campaign, which we'll share in the chat, that Kristen and Lori and I for years got to work to develop. But Kristen's question is actually about your experience. So as a Black woman and a physician who happens to be a breast cancer patient, have you experienced barriers to quality care and or racial biases in navigating the breast cancer continuum of care? And I know you kind of hinted at some of this earlier, but if you know Kristen, you know she's going to ask it like it is. And so I appreciate her raising it, because I still, every time I hear about these things happening to you, I think it reiterates that it's not about where you might be stationed or how much experience you have. These are real issues that we still face. So I'll let you answer it.
So thank you for that question. And the real answer to that is yes, I have had these experiences that were experiences that honestly could have changed the way I interacted with my healthcare if I didn't know better. I always tell my residents that one interaction with a patient can change the way that they, as well as their family, and so their legacy, interacts with healthcare. It is not a good feeling to be ignored, and it's never something that should be taken lightly. However, I have had the experience where I couldn't get a clinician to even call me back. They actually left that discussion to, and have nothing against the researcher, the research assistant. However, I would expect that at least to get my questions answered and to understand what the reasoning was behind some of the decisions that were made, that I could at least get a call back. That didn't happen, and I was just told to go back to my and this was for consultation, and just to go back to my team. I've also have to say that in my experience of my first experience, there was a time where I had, and it's always difficult for me to talk about, because I'm a clinician, I'm a surgeon, I know better, and I knew better at the time that I needed to be seen, but I was so tired and so worn down, and oftentimes patients can get to that point, that someone told me, no, I'll just see you on Monday. And I was like, no, I really think I need to be seen today. And they were like, no, I'll just see you. And so that kind of led to a admission to the hospital over that weekend, ultimately losing my reconstruction, and may have lost my reconstruction anyway, but it always is a very sensitive area for me to talk about, that I was not more of an advocate for myself. And so when we talk about being advocates for yourself, it may not be as easy as we foresee. And so I always now tell my patients that my threshold is so low. And I also give I have business cards. And so my cell phone number's on my business cards, and I give them out to all of my patients. And I'm like, call me if you need me. My threshold's low. I don't mind you calling me, and I love giving good news. So if you tell me that something is a problem, we figure out that it's not a problem, we can celebrate that together. And that is something that gives me a moment of joy. So I think that making sure that we are understanding how patients may interact and advocate for themselves, and what it might look like, and how scary it might be for patients to really do that, and worry that they may in some way offend or make their clinician angry at them for some reason.
Wow. First, thank you for your vulnerability. And I think that, that question and your answer highlights so many things that we've now learned, right? About the importance of that physician and patient relationship, and having the ability to be your own advocate and find some support to make that happen. Sometimes those conversations are tough. And so I think, having physicians like you raise these points, because it's not something you studied. You've walked in your own shoes, and now you're able to go back to your peers and say, we got to do something a little differently here. And one of the things that I'm going to point out actually ties to Brandon's question he just sent through about how has COVID impacted the treatment of patients over the last 2 years. What I think is interesting is that you said this early on, when a lot of people were like, oh, telemedicine, what are we going to do? It's going to, impact care negatively. We're going to have worse outcomes, poorer communications. You have been very fascinating about this. And I think that you shared about your cell phone. And I'd like to highlight that Lori always says people don't abuse it when she gives it to them. But I'd love for you to answer the question from two ends. One, in general, how do you think it's impacted patients' treatment over the past 2 years? But if you can share with everyone how you feel it's actually improved your care. I know that because I've been working with her on this issue, but I think it's more of those, what did we learn and what should we continue from COVID? It wasn't all a loss. So Lori, let's hear more about that.
Oh, thank you very much. I think that one of the things that we all need to make sure that we are doing is communicating. It's a basic thing. However, it is central to making sure that we are getting what our patients need, and that's what's important. And so I find that COVID, having the opportunity to talk to patients, to interact with patients. And I spent a tremendous amount of time really just sharing information, bringing up the topic. What are your thoughts? How can, where do you think we're going with this? And really understanding what my patients need, because it's really not about trying to, in that moment in time, it's really more for me about giving information, sharing, and making sure that well-informed decisions can be made for who they are, where they are in life, and that those decisions are made with good information. And so our goal is to make sure that the information is developed and discussed in a way that patients can hear it. And then also that those discussions are really about making sure that the information is vetted, and that the information provides what they need to make their decisions. I am a true believer that patients have autonomy. They have autonomy to make decisions, but my job is autonomy comes out of me spending the time to give the information and making sure that that information is correct.
I love that. I see that you've gotten another one. Someone said, congratulations, Dr. Wilson. Thanks so much for sharing your story. Great conversation. And another person thanking you for answering the question. We are getting close to the end, so I'm going to see if there are any other questions, but there is one last one that I did actually want to ask you that we were excited because I think that when you think about cancer and disparities, we know that there is so much more to do, especially after COVID, right? We know that women in our community actually we're facing more barriers, right? We know that screening now is an issue again. We had made so much progress with ACA and access to healthcare coverage. And now with COVID, we've got to get people back in for screenings. We've got to get those behaviors again where they're coming in and building those trusted relationships with physicians like Dr. Wilson. But with that in mind, we want to know, what are you excited about in your coming work, and what is giving you hope right now? And hopefully that continues to inspire us as we continue our work.
So I am excited. Honestly, I'm really excited about the patient-centered advocacy that involves patients in the community learning more about their health, learning more about how they can use that advocacy for good for themselves and for those that they advocate for. I love the fact that I see patients that, I see women and men who are advocates for themselves, and we oftentimes start at one particular place and they learn all about a particular disease process. And then at the very end, they understand how they can use that to really change the way things happen for them and for those around them. I honestly love that, because I think that it's important to have your own voice. One of the things that I love, and I tell this story over and over again, is about training at Howard, is because that's where I gained my voice. It's where I felt that I could actually say something. Someone would listen and things would change. There's something so empowering in investing in knowledge and understanding how that knowledge can be used, really doing your part, your due diligence, and then knowing that when you do that, that you can absolutely change the world. You know, you can change the way that people do things. You can change the way that they listen to you. You can change the way that they decide to do a particular thing for your advocacy, your community. And that is number one for me. Number two, the fact that there are so many wonderful targeted treatments that are coming down the pike, and that those targeted treatments are going to really change the way that we look at the molecular level of cancer, of breast cancer, and how we're going to adjust and improve. And then, there's nothing better than understanding that disparities isn't just one thing. Disparity work is work that we all need to be a part of, but we have to understand that disparities, there are many things that should be incorporated in the understanding of what a disparity is. And so disparity work really becomes the underpinning of what I'm hopeful, excited about, and plan on working diligently as dean, associate dean, and surgical oncologist and chief of the division of surgical oncology. So.
Well, thank you so much, Lori. I have one last question that I know came earlier today. And I know that oftentimes when we think about breast cancer, we think of women. But just like the disparity with Black women, right, being impacted more and dying more from breast cancer, we know that our Black men are facing those same disparities as well. So can you actually just answer the question of, do men get breast cancer? And can you share a little bit more about how breast cancer impacts men? And then if you've worked with any male patients, if you've got any tips for clinicians, physicians, or those that may work with this community.
And thank you for that question. I think that I've always had a few men in my practice that have had breast cancer. The thing that I've seen over time is that they're oftentimes in the very beginning, probably 10 years ago, 15 years ago, there was a bit more shame that was associated with the diagnosis. And so there was a bit more of a time delay. We are still experiencing time delays because, as you said, with COVID and all that has gone on, patients need to develop new strategies for coming in and making sure that those things are happening. But for our male patients, they do get breast cancer. It's about 1.5% to 2% of the breast cancers that we talk about. And men present in a way that usually is a lump or mass. Men have breast tissue. That breast tissue is a smaller amount, but they oftentimes will present with a abnormal finding like a lump. They will oftentimes not come when they first notice it because they don't think of it as a diagnosis that they may need to be seen very quickly about. But what we also see is that treatments, surgical targeted treatments and treatments of radiation are all definitely methods of treatment that men benefit from. So.
Thank you so much. And I think that one of the things that you highlighted in your answer, even with men, is oftentimes that sometimes, right, there can be barriers based on stigma and shame. And one of the biggest things we can give to everyone here, as we're coming back from COVID and building back better, let's empower patients as we're taking action this Breast Cancer Action Month. And I'm going to hand it back over to Brandon and say a big thank you to Dr. Lori Wilson for sharing the incredible work that you're doing and trailblazing, and for your vulnerability and honesty. Thank you so much, Dr. Wilson. And thank you to the NMQF team. Brandon?
Oh, yeah, no, just following up with what you led with, Shyrea. I always love hearing from Dr. Wilson. I think I heard from her the first time, maybe 3 or 4 years ago at a Tiger Lily event. And I was like, well, we have to get her at NMQF to speak to our larger audience and community. And she always comes through and she always educates and and helps us out. And then so we really do appreciate you, Dr. Wilson, and all that you do. And your honesty and your vulnerability. I think that's something that came across on a couple of times. And then Shyrea, who always comes through for us and has been working with NMQF and since before, and it was before we worked with her in Congressman Kelly's office. So just appreciate you and all the work you do. With that, I look forward to next weekend's talk and seeing everybody again. And I always want to thank Keiko for making sure all this happens. Everyone have a good weekend.
Thank you.
Thanks so much. Be well.